Hello, my name is Amir. I'm pleased to say that I'm a dental surgeon and I'm here to talk to you, a budding dentist, a general dental practitioner, a midwife, a nurse, or anyone. But especially you, about probably the second commonest form of heart disease that there is. To talk to you about a killer that creeps up behind you with maximum stealth, crawls underneath your skin, slowly but surely, causing damage to your blood vessels, to your arteries if you like, so that you end up with atheroma. That is the major disease which obstructs blood vessels, arteries if you like, so that they swell and burst. And if these blood vessels swell and burst, as they do in your coronary arteries, you will end up with an infarct, a coronary thrombosis, or what we call a heart attack. And if these blood vessels swell and burst, as they are particularly likely to do so in your brain, you will end up with an accident, a cerebral vascular accident, or what we call a stroke. The so-called silent killer is called hypertension, and I'm here to talk to you about that. Hypertension is a condition in which the blood pressure is raised. That is, we normally like people or patients, our patients, to have a blood pressure of not more than 140 millimeters of mercury systolic over that of 90 millimeters of mercury diastolic. You've taken blood pressure, you know how to get these levels, so I need not bother wasting your good time. But for those of you who've just bought your monitors and are new to this game, it may be a little bit daunting because you have systolic blood pressure to think about, you have diastolic blood pressure to think about, you have millimeters of mercury to incorporate into this equation. And so just to clear the air, blood pressure, whether it's taken by your GP or his nurse, your midwife or your dentist, or by your good self at home, is expressed as two numbers. And is written as a fraction. The higher number sits at the top of the fraction, and the lower number sits at the bottom of the fraction. The higher number is called the systolic blood pressure. That is the pressure within your blood vessels, within your arteries, when the myocardium is contracted at its peak against millimeters of mercury. And we normally do not like people to have a systolic blood pressure of more than 140 millimeters of mercury. The optimum is that of 120 millimeters of mercury. The lower number, which sits at the bottom of the fraction, is called the diastolic blood pressure. That is the pressure within your arterial system when the myocardium is filling up between contractions. And we normally do not like people to have a diastolic blood pressure of more than 90 millimeters of mercury. The optimum level is 80 millimeters of mercury. Now, the World Health Organization in Geneva says that if your blood pressure is 160 millimeters of mercury systolic over that of 95 millimeters of mercury diastolic, then you are hypertensive. Now you have to be very careful about the reading of the blood pressure, because blood pressure varies. Blood pressure varies from time to time, and blood pressure varies with the time of day. Blood pressure varies with the state of the patient, and blood pressure varies with the expertise of the person who's taking these recordings and interpreting them. Blood pressure varies whether you take a phase 4 or the phase 5 of the diastolic blood pressure. There are many variables. And it's only when these levels are persistently raised, constantly raised, can you say that there is a disease process in situ. namely that of hypertension. Why do some people get hypertension and some people don't? Well, there is a very important genetic influence. Hypertension runs in families. Hypertension runs in your genes. So if your parents are hypertensive, then you are more likely to be hypertensive and develop it. It's an important variation according to race on the whole. That is third world countries, or developing countries as you like to call them these days, do not generally have hypertension. They have poverty, misery, and no money, but they do not have hypertension. When you bring people from the third world and introduce them in this part of the world, they like it. They love it. They develop it. So it's something to do with race, and it's certainly something to do with environment. Environment is certainly important because things you eat and drink may certainly influence whether or not you're hypertensive. And the one thing that is proven, of course, is the amount of sodium, salt that you consume in your diet. Patients that are hypertensive have an abnormal handling of body sodium. That has been proven to exist in the red cells, for example. A lot of hypertension is induced by alcohol. This was a comparatively new school of thought 15, 20 years ago, but it is now a well-established fact that chronic alcoholism is an important cause of chronic hypertension. Cigarette smoking is a huge factor when it comes to atheroma and arterial disease, and the combination of cigarette smoking and drinking alcohol are huge factors when it comes to hypertension. Obesity is a relatively unimportant factor when it comes to hypertension, but is a factor. Age is the most important factor because it is the normal part of aging, the normal process of getting old, that your blood pressure goes up. This is because you have atherosclerosis or arteriosclerosis vessels, and therefore the resistance to blood flow from the heart is going to increase. And so the heart has to increase its perfusion pressure in order to accommodate it. And so the blood pressure goes up and up. So these are the number of factors we know about: genetics and genes, race and environment, obesity, drinking booze, cigarette smoking, atherosclerosis, and age. How does hypertension occur and what happens? Well, there is an increase in the peripheral resistance. The small arterioles in the body narrow, almost certainly in the first place under some sort of a biochemical control. And if you narrow millions of small arterioles, you increase the resistance to blood flow. And in order to maintain an adequate circulation, an adequate blood supply to vital organs such as the brain or the kidneys, the heart has to increase its perfusion pressure, and the blood pressure goes up and up. So that's how it occurs, and that's what happens. Now, there are two sorts of hypertension. That is 99% of all of you, of all patients that are hypertensive, have a thing called primary hypertension, or as we call it in the United Kingdom, essential hypertension. This is a euphemism to describe the fact that we do not know what's causing it. So we call it essential. But essentially, we do not know the cause. A very small percentage of people, and I exaggerate here, but let's just call it 1%. 1% of patients that are hypertensive have a cause for their hypertension. And as you can imagine, a great deal of money and effort is spent on that cause, because if you can find the cause and do something about it, you can stop that patient from being hypertensive. So what kind of causes might there be? Well, the first thing is that they may have renal disease, kidney disease, so that chronic diffuse renal disease, chronic glomerulonephritis, chronic pyelonephritis are all associated with hypertension, because you know in the kidneys there are hormones, namely angiotensin and aldosterone, which come into play when there is a drop in the perfusion pressure in the renal system because of disease. And they retain sodium to compensate for this, and they cause spasm of blood vessels, so that the angiotensin aldosterone mechanism comes into play with anyone with chronic diffuse renal disease or with kidney disease as a compensatory mechanism. But in order to compensate, the blood pressure goes up and up. So if you have a patient that is hypertensive, you may say to yourself, maybe my patient has renal disease, chronic diffuse renal disease. The second thing you might think about, and the second cause of patients that do have a cause for their hypertension, is an endocrine disease, an endocrine lesion. And there are two important endocrine diseases that are complicated by hypertension. Both of them concern the adrenal glands. The adrenal glands, if you recall, are those things which sit on top of the kidney and are divided into the medulla and that of the cortex. They have an entirely separate origin and an entirely separate function. A tumor of the adrenal medulla is called the pheochromocytoma. It's a tumor of the adrenal medulla which secretes adrenaline and noradrenaline. And that puts your blood pressure up by causing spasm of blood vessels. And patients with a pheochromocytoma, with this disease, complain of attacks in which they get palpitations and severe headaches. If you were lucky enough and took the blood pressure during an attack, you will notice that the blood pressure is high. And diastolic blood pressures of 120 and more, and systolic blood pressures of 200 and more are compatible and consistent with a pheochromocytoma during an attack. But outside an attack, it's perfectly normal. So you would think of a pheochromocytoma in any patient with hypertension, because sometimes that hypertension becomes sustained and the relationship to the attacks disappears. The second sort of an endocrine lesion complicated by hypertension is called Cushing's syndrome, where there is hypertrophy of the cortex of the adrenal glands, again with sodium retention because of excess cortisol, and that puts your blood pressure up and up. And the third main cause of patients that do have a cause, an actual cause for their hypertension, is a congenital cardiac disease. That is 6 to 8 kids per 1,000 born in the United Kingdom are born with some sort of a congenital cardiac lesion. In the majority of cases, this is of a minor importance. Not like this one. This is called coarctation of the aorta, where kids are born with an actual narrowing in their aorta. So the blood pressure has to increase, rise to get the blood above the narrowing, to get the blood to the peripheral parts, to get the blood to the lower parts of the body. And so the blood pressure goes up and up. And that is called coarctation of the aorta, and is a congenital cardiac lesion. So there are three very important causes of patients that do have an actual cause for their hypertension: renal disease, endocrine disease, and congenital cardiac disease. Mostly and mainly, they do not have a cause. But you should always look for a cause, because if you can find the cause and do something about it, you can stop that patient from being hypertensive. Now, there is just one other type of hypertension. That is whatever the cause of hypertension. And whoever may suffer from it, you can cut off, separate, put aside, whatever you like to call it, a group of people or patients in which the hypertension is extremely bad. We have a name for that. We call it malignant hypertension. So someone with essential hypertension may have malignant hypertension. Someone with a pheochromocytoma may have malignant hypertension. Some patients with chronic diffuse renal disease may have malignant hypertension. Any patient with Cushing's syndrome may go on to develop malignant hypertension, whoever develops it. And for whatever reason they develop it, this is an extremely serious state of affairs. Because in malignant hypertension, there is not just an increase in the spasm of these blood vessels, but they actually become injured and damaged and occluded. And the end result is widespread tissue damage due to ischemia. And patients with malignant hypertension, if left untreated, die of renal failure because of kidney disease, because all the arterioles in the glomeruli are damaged and injured and occluded. Now, there's a sign for malignant hypertension that is extremely important. Obviously, the blood pressure would be high, and indeed the blood pressure is high, and diastolic blood pressures of 120 and more, and systolic blood pressures of 210 and more are compatible and consistent with malignant hypertension. But that is not what defines it to be malignant. What defines it to be malignant is that if you were to look with an ophthalmoscope in the back of the eye, you will notice that there is swelling of the optic nerve disc, a condition we call papilledema. A swelling of the optic nerve head, if you like, the second cranial nerve, because the pressure inside the brain is increased. There is a raised intracranial pressure. And as well as papilledema, you often see exudate and hemorrhages in the background of the eye because of the damage to small blood vessels I've already talked to you about. So you diagnose malignant hypertension not so much with a sphygmomanometer, but with an ophthalmoscope. Now, the danger of a raised blood pressure is this. A raised blood pressure encourages atheroma. That is the major disease which obstructs blood vessels. And if you have a raised blood pressure inside your arterial system, you are more likely than not to damage the fine mosaic endothelial lining, and deposits of fat and platelet will begin to accumulate and aggregate there, and you end up with atheroma. I say that to you now because I used the term earlier on, atherosclerosis, but it is the atheroma in the lumen that is the most important thing. So that patients who are hypertensive have more coronary artery disease, more peripheral artery disease, more cerebral artery disease, because they're hypertensive. If you have a raised blood pressure, that puts an extra strain, an added strain on the left side of the heart, and you may develop heart failure, left heart failure, or if you're an elderly patient, that may be enough to tip you into left heart failure. And you recall I talked to you about that when I was talking to you about left heart failure last time, but it's exactly the same this time. Blood vessels or arteries in which the pressure is raised may just swell and rupture and burst. If these blood vessels swell and rupture and burst as they do in your coronary arteries, for example, the anterior descending branches of the left coronary artery at the front of the heart, or the circumflex branches of the left coronary artery at the back of the heart, you will end up with a coronary thrombosis, an infarct, or what we call a heart attack. And if these blood vessels swell and rupture and burst as they are particularly likely to do so in your brain, in the circle of Willis, you will end up with an accident, a cerebral vascular accident, or what we call a stroke. So there are three very good reasons, therefore, to detect patients that are hypertensive, to prevent them developing further coronary artery disease, peripheral artery disease, cerebral artery disease. Many patients, millions of you who are hypertensive, are symptomless. You have no symptoms. You're not aware of it. You're not concerned by it. You not even know that you have it. And therefore, it is very important to detect these patients. And you know there are multiple surveys that go on. And of course, your chances of being picked up is greater if you attend a medical examination for joining the army, the navy, for employment, for retirement, or if you were to visit the dentist. I routinely measure the blood pressure of all my patients, and I pick them up by the week. And I have already told you about the danger of death from renal failure with patients with malignant hypertension if they're left untreated. The last thing I want to talk to you about is the treatment of patients with hypertension. That is, we can treat hypertension with drugs. And we do treat hypertension with drugs, and billions of pounds later, and millions of happy, healthy customers later, we can safely say that drug treatment, when it comes to hypertension, is extremely successful and effective. Having said that, we don't treat everyone with drugs. I mean, you don't treat a gentleman of 86 with a blood pressure of 180 over 110, even though he's theoretically hypertensive, because you have good sense, good common sense, which will tell you that it is the normal process of getting old, the normal part of aging, that your blood pressure goes up a little, because you have atherosclerosis, and therefore the resistance to blood flow is going to increase. So the heart has to increase its perfusion pressure, and it goes up and up. And you know these drugs are not like sweeties. They have side effects, serious side effects, and therefore they're not well worth doing. If you have a young patient who's 25 with a diastolic blood pressure of 105 and is symptomatic and you can't find the cause for that hypertension, you treat them. Because you know they have 60 years or so to live, and you don't want them to have a coronary thrombosis. You don't want them to have a heart attack or a stroke. You want them to fall in love. You want them to get married and have kids. And even though that these drugs have side effects, they're well worth accommodating because of the likelihood that they may do some good. You need not know all about these drugs. I'm going to give you a list and I'm going to go through them. It is the technique which is the most important thing. And the technique is to decide whom you're going to treat. And then after that, be very sensible about it and use one drug only. But then come back and realize and appreciate that patients may not respond to one drug and you may need to use 2 drugs. And again, come back and realize that patients might not even respond to 2 drugs and you may need to use 3 drugs. The drugs themselves, well, before I talk to you about drug treatment of patients with hypertension, I think it would be wise for me to talk to you about non-drug treatment of patients with hypertension first. Because if I told you that obesity was a risk factor, and drinking too much booze, and smoking too many cigarettes, and eating too much salt, and not enough exercise, and eating too much red meat were all risk factors, it would be sensible to correct these before you put patients on drugs which may poison them. So you would slim down your hypertensive patient, you tell them not to go boozing, you tell them not to go smoking, you tell them not to have so much salt, you tell them to have fish and chicken and exercise, and if you can get by just giving them good, sensible advice, that is great for you and is great for your patient. But patients are funny. People are funny. They might not listen to your advice. And you say to yourself, even though my patient is funny, I'm still going to give them treatment, therapy. And the kind of drugs you would use, well, you could use a diuretic drug. That's the simplest form. You recall I talked to you about diuretics when I was talking to you about treatment of patients with heart failure, and I told you that the sheet anchor of therapy in patients with heart failure was the use of diuretic drugs, drugs that make you pass more sodium and therefore more water. So you get rid of the edema, you get rid of the congestion, the venous fluid drops, and the fluid in the body cavities disappears and the heart can resume her activities in normality. And drugs such as chlorothiazide by oral agents were extremely effective. But how would a diuretic drug work in patients with hypertension? Well, it would reduce the blood volume a little because it would dehydrate them, and that certainly would have an effect. But diuretics do more than that. They stabilize small blood vessels and prevent them from going into further spasm. So they have an effect other than volume depletion, and they're given on their own, and they are very effective on their own. The second sort of drug you may consider using is the beta-adrenal receptor blockers, the so-called beta blockers, drugs such as isoprolol. We came across this before, and I told you that beta blockers stop the heart from accelerating, and they reduce the cardiac output. Blood pressure, as you very well know, is a combination of cardiac output and peripheral resistance. And therefore, if you can lower the cardiac output, you will lower the blood pressure. The third group of drugs that you may consider using are the vasodilators. We came across this before, and I told you drugs such as nifedipine, calcium channel blockers are very effective. And the fourth group of drugs that you may consider using are the angiotensin converting enzyme inhibitors, the so-called ACE inhibitors, and drugs such as ramipril are extremely popular and extremely effective. As you recall, angiotensin converting enzyme converts angiotensin 1, which is ineffective, into angiotensin 2, which puts your blood pressure up. If you can inhibit it, you stop blood vessels from constricting and going into spasm, and so the blood pressure falls. So there are 4 groups of drugs that you can can consider using, starting with the simplest, the diuretic and the chlorothiazide, and ending up with the most complicated, the angiotensin converting enzyme inhibitors and the ramipril. The idea is that you use a very simple approach and see if you can get by just using one drug, and then coming back and realizing the patients may not respond to one drug and you may need to use 2 drugs and on occasion 3 drugs. Realizing that these drugs have side effects. Some of them have serious side effects, and I'll come back to you and explain them to you. And finally, realizing that if you give patients 2 or 3 drugs to be taken 2 or 3 times a day on top of what they're already taking for their other illnesses, they might not take them. So there's always going to be a question with what we call compliance. Thank you very much for listening, and I hope it's been helpful.